There we go. I just took a minute to look around at who's not here, and then I thought, maybe I was supposed to record today. So one aspect of how we currently prescribe hormonal birth control, and these do have to be prescribed. They are not over the counter in this country, is that they tend to be at a certain dose and it doesn't account for weight. So the more you weigh, the slightly less effective that they are. And then especially for the one that is mini pill. So mini pill is considered the ones that are progesterone only. Those actually have a much lower dose of hormone than the other hormonal methods that are both progesterone and estrogen. And when you are taking those every day at the same time, because it's low dose, you want to take it at the same time every day before the dose or before the concentration in your body falls too low. Because if the concentration suddenly falls too low, boom, you can ovulate. And keep a high, consistent level. So if you're taking low dose pills, it's really important to take them at the same time every day. And be very consistent about that.
The time window for that, like, is there like a certain time, like, do you have to take it exactly the same?
You really should, because it's gonna depend sort of on some individual person factors, like, how much do you weigh? And how often are you individually, like how great is your kidney function that you're peeing it out over time? So pretty important to, on those mini pills, take at the same time every day. And my perception is that they try to make for standard pills, they try to make the hormone level last long enough in the body that if you miss one day, it's still going to be a decently high level, but missing one day on a mini pill is much more, will not hold the levels constant the way you might need it to be. Yeah. So the next category kind of crosses between hormone method and some other method. And this is a category of IUDs, which stands for intrauterine device. Intrauterine device, and most people just call it IUD. And you've got some pictures here of some real IUDs. So this one is what the version called Marina would look like, which is a hormone release IUD. And this one is more like the version called Paragard. Paragard, which is non-hormonal, and it tends to be made out of copper. But they're about the same size, and you can see the size compared to the hand here. And the way that these work is the T part, the T junction arms of this sit up inside the cervix. And then the straight down part goes through the cervix, and then there are some strings. So I want to use go back to this picture and kind of draw in how this would be situated. So kind of like that. So they're a T shape, and the crossbars of the T hold it in the cervix. The vertical bar goes through, and then there's some strings. And these work in one of two ways, depending on what they're made out of. So go back to our info here. Yeah, that'll be fine. So if they are hormonal, they are releasing slow release, constant estrogen, progesterone. And those hormones are basically slowly being released over 5 years. Very slow release. So Marina is a 5-year release time. Paragard, because it's made out of copper, it's not releasing anything, but it tends to be up to 10 years. And Paragard works in a method that the copper, how do I want to write this? The copper is altering cervical mucus, also sperm function, let's say. And the copper is just sort of, staying in the IUD, but having copper in that area of the cervix will prevent sperm from being to swim up through the cervix very well. So these are very long acting. So we call this long acting reversible contraception. Long acting reversible contraception, or LARC, LARC. IUDs are really good for being long acting. They do have to be inserted by a physician. You cannot do it yourself. You should not do it yourself. They have to be prescribed. They have to be inserted by a physician. It's kind of painful one time, and then you get 5 or 10 years of contraception afterward. You can also change your mind. Like if you say, oh, I don't want to have it anymore, you can make an appointment, get it removed. You don't have to keep it for 5 years or for 10 years. So our boys that are 4 years apart, I had it for 3 plus years, and then I said I want to have another child, have it removed. So it's really a good long acting contraception. Hurts some to get it put in. The risk with these is sometimes these can move. They should not be moving. They need to stay in the cervix, stay there. Sometimes they can fall out, which is unusual. Sometimes they can migrate over and get wedged in the uterus wall. And I had this happen to a student before, and it was just really bad for her. And there's a low risk of that, but it does happen. So very, very good in the long acting, the long-term protection. Slight risk of moving, which is not great. And go back to your chart here. There's something very important about all of them. So we've been talking about these for contraception. None of these prevent sexually transmitted infections except condoms and abstinence, definitely. But these we're talking about for contraceptives, not for STD protection. And actually having IUDs makes you more susceptible to STIs because it's adding a little bit of foreign material into the cervix. And you don't want to be using LARCs if you are at high risk of STIs. That's important to note. Important to note. So these are not quite a surgery. So they're not surgical methods. Mirena would be a hormonal method. Paragard is more like, kind of like a barrier method in a way. It's like a chemical barrier, if you go to classify them. And then we come to the surgical methods, which are vasectomy, and tubal ligation is what they are technically called. So we'll start with vasectomy, which is the male version of surgical contraception. And they've got a good picture here of what vasectomy is. So it's cut the vas deferens, and they're showing two here, one on each side. So cut the vas deferens and then ligate it, which means to kind of sew it up or tie it off so that there's no route for sperm to leave the testes. Vasectomy. Vasectomy is outpatient. There is a King faculty member that's still here that got a vasectomy in the morning, and then they went and taught their classes the rest of the day. So it's not very invasive. It's maybe some painful, but it's really a very minor procedure from a physical standpoint. Lately, there has been a lot of talk and chatter about people saying that vasectomies are reversible. They are not easily reversible. You can have it reversed. What would happen is there needs to be a little bit of stretching of the remaining vas deferens and sew it back together. And that may or may not be successful. So yes, technically they are reversible, but you don't want to have a vasectomy or encourage your partner to have one if you think that you don't want to have permanent contraceptives. Technically reversible, don't plan on it. Something else important to note about vasectomy is there will not be sperm coming out of the testes, but there will be the fluid components of semen. You would still have the fluids from the prostate and the seminal vesicle and the bulbourethral glands. So there is still ejaculate, they're just not semen in the ejaculate. With a vasectomy, there has to be, it is advised to observe what's called the washout period. So right after a vasectomy, it is very possible and indeed likely that there are some sperm in the distal vas deferens that are still there. And just because you cut and tie down here, that's not going to do anything for the sperm that are already past that point. So there is a certain number of days, and it can be called the washout period, to keep using other methods for a few days. There have been plenty of cases where a man goes to all the trouble of getting a vasectomy. It's not as bad as he thinks. Doesn't wait for the washout period or doesn't use some other contraceptive during the washout period and does conceive a child right after the vasectomy. So check back on your chart back here and take a look at, where's that? So on your chart, this is referred to as male sterilization. That's vasectomy. And with perfect use, it's 0.1% failure rate, which is really low. And then it says with typical use, it's 0.15. And you might think, how can you not use that correctly? That's referring to, oh, you didn't follow the instructions for that washout period. That's what the difference is, perfect versus typical use. Both of them are really low failure rate, but there is still a failure rate. It's just surprising. And that kind of depends on, did the surgeon do everything perfectly or not, which you can't really control that. You're depending on them to control that. So that's vasectomy. Let's now look at the female equivalent, which has some different names. So its specific name is tubal ligation. Tubal ligation. And it's the same concept. So cut the uterine tube, cut the fallopian tube, fold it over, sew it up, or tie it up. Tubal ligation. The other ways that people describe this is they may say, I had a tubal, I had my tubes tied. Those are the major ways. This is a much more difficult surgery. This is a major surgery. It's not like vasectomy, where if you can just have like the smallest little incision in the scrotum and get right there. This is deep to the pelvis. So the easiest way to have tubal ligation is to have it right after a C-section. I have a tubal ligation after my third C-section. They're already in there. So that's a good time to do it. If not, it is a separate major, fairly major abdominal surgery, and there's more of a recovery time and so on. It does not do anything to the ovaries. It's specifically fallopian tube based. And the woman would be continue to ovulate and the egg gets sucked in and it just kind of never leaves, never get fertilized. That's okay, just an egg. It's this really is not reversible. It's technically possible, but it's not a thing that people try to do. So before we go to these last few slides, I want to look back again at your chart right here. And we've kind of compared these methods to each other and talked about typical use, perfect use, low, medium, high failure rates. And tubal ligation, once that's female sterilization. This is tubal ligation here. There's no difference between typical and perfect use failure rate because there's no using it. It's done or it's not done. And it's a 0.5% failure rate. And then let's review what was our cutoff this year for low failure rate versus high failure rate. Yeah, so we were saying if it's less than 5%, that's low, and if it's greater than 10%, or was it 15?
15. I thought it was 15.
Yeah, so I wanted to check this, make sure. Greater than 15, it's high. And then if it's something in between there, we're saying that it's a medium failure rate. So that's how we're classifying them. But if it's really important not to get pregnant, some of these failure rates might, in your mind be high. And so, for example, this is saying that 1 out of every 200 people that has a tubal ligation can still get pregnant in a year. And that's kind of surprising. That's kind of surprising. And if you're relying on a method that has a pretty low failure rate, even with perfect use, like male condom, 1 out of 50 couples in a year of perfect use would still have a pregnancy. And that's very, very important to know, especially in current times when everybody has an opinion about birth control and abortion and what people should have done and what precautions they should have taken. It's really important to note contraception has a failure rate. So if it's critical, at some point in your life to not get pregnant, double up, because then you're multiplying low chances together. That can help. If it's not critical, it's going to work pretty well if you use things perfectly. But if it's critical to not get pregnant for a variety of reasons, if you multiply 2% by well, let's say typical use, multiply 18% by 9%, that really lowers the chances. Really does. But all contraceptive methods can fail, and then when you get closer to my age, you'll have friends that are like, I have a friend, it's the same, well, same friend that had the vasectomy, and this was before the vasectomy, and they said, oh yeah, we're having a new baby, and I said, you're kidding, just not right. He wasn't kidding. Like, oh, really? Congratulations. And it's, they are a wonderful little child, loved by everyone, but surprises happen. So that brings to these last few slides. What if a surprise happens and you know it? What if you need emergency contraception? And it's really important to talk about what this is and what this isn't. So this particular drug, the actual name of it is levonorgestrel. Sorry, levonorgestrel. And this is a progesterone based drug. And what this is very high single dose progesterone. And this is the one that you can buy over the counter. It costs about $40. And one of the names of it is Plan B. It's one pill, it's one big dose of progesterone. And what this level of progesterone can do is two things. It can prevent ovulation. So depending on the timing of where you are in your cycle, this prevents ovulation because it's a really high dose of progesterone. And it also can prevent implantation. And which of those things it's going to do is depending on where you are in your menstrual cycle. But what it will not do and what it cannot do is reverse implantation. It cannot reverse implantation. There are, and that's why it has a time frame on it. So on the instructions, it says take as soon as possible within 72 hours after unprotected sex. Broken condom would also be a time when someone might need this. The sooner you take it, the better it will work, because if implantation has already happened, this will not do anything. And there are plenty of healthy children born that implanted before this, and it won't reverse an implantation. It will prevent implantation, and depending on whether you ovulated or not, it will prevent ovulation. That's this. Oh yeah, this is the data on how effective it is based on timing. So timing is important. It's 95% effective at preventing pregnancy within 24 hours. It's 89% effective within 72 hours. So timing is very important because once there's been implantation, it won't do anything. So I want to add that onto our early timeline. So we've got last menstrual period, that's day 0. We've got ovulation is usually around day 14. Implantation, we had said that was what, 4 or 5 days after? Day 20, around day 20. And Plan B, or levonorgestrel, you take it outside of this range, it's not going to do anything. If you take it after implantation, it's not gonna do anything. So based on our medical definition of pregnancy, this does not cause abortion. There is a pill that does cause abortion. It's not this. It's not the one that you can get over the counter. And if you wait too long, it's not going to do anything. It would be too late. And actually, most of the evidence about these morning after pills, we know for sure that they do not end the pregnancy that has implanted. They definitely can delay or prevent ovulation if it didn't happen. They can help block fertilization. They can stop an egg from implanting, but most of the time, what the way the pills seem to be working in animal models is it's acting even before the blocking of implantation. So these are not abortion pills. There are abortion pills, that's something else. The thing that is abortion pill is a drug called RU486. That's what this is about, which is called mifepristone. Mifepristone. And so if you're reading about people trying to get abortion pills through the mail, it's this mifepristone or RU486. That one does reverse implantation and will cause abortion and actually terminate a pregnancy. But these are not the same thing. They're not the same chemical. They're not acting at the same level. They're not acting at the same time. So this one, it is pill-based. It's actually 2 pills. You take one, then you take the other. And this is going to have a lot more side effects, but it also has a time limit on it. Needs to be used early pregnancy, not late pregnancy. These are separate things, separate chemicals, not the same thing. So this is what there's a lot of debate now, like, will you be able to get this through the mail? Will you be able to get this from another country? What if your state tries to block it? They're talking about mifepristone and drugs like that. Separate thing. Mifepristone is not a contraceptive. So I want you to have heard of it, but I'm not considering it. It's not on that list. It's not preventing pregnancy. It's ending pregnancy. Mifepristone. Make sure we get over here on our list. When can Plan B be effective? Only very early on. Can't wait too long on that. Okay, and then now we're going to move on to pregnancy things. So we're going to assume there is a pregnancy, not a miscarriage, keeps developing, and talk about some maybe happier topics. This one. And what I have set up this section to include is things that I feel like people don't know about pregnancy until they have been through it or their partner has been pregnant. So kind of some lesser known facts or interesting things that happen during pregnancy. And there was not a quiz today, by the way. I never did write one. So the first thing to note about pregnancy is what is actually dangerous during a pregnancy, because there's a lot of people that say that certain things are dangerous, and there are some things that are truly dangerous during pregnancy. So some of the things that are truly dangerous during pregnancy, is a very high fever in the mother. So anytime the mother has a very high fever, that can be damaging to the fetus, especially if it's first trimester. So protecting the mom's health is always very important, protecting fetal and embryonic health. There are certain infections in the mom, like one called Listeria, one called cytomegalovirus. If the mom has hepatitis, or if the mom has varieties of sexually transmitted infections, that can be damaging to the fetus. This one's been in the news. What is that? You heard of Listeria?
Is it the one that has that commercial where the reduced these real effects?
It's possible.
And like, if you or anybody know have ever died of hysteria, please call them.
I don't know, because we don't get network anymore, so I don't watch commercials. So lately, Listeria has been in the news from food poisoning outbreaks. And there's a lot of kinds of food poison outbreaks, and Listeria is especially dangerous for fetuses. So it's some dangerous from the mom, it's especially dangerous for the fetus. And it is a version of food poisoning. And you can get it from so many things, like fresh produce that's contaminated, and sometimes hot dogs, and sometimes deli meat, and a lot of the things that people say that women shouldn't eat during pregnancy. It's to try to prevent Listeria. High levels of alcohol. So being alcoholic would be damaging to a pregnancy. One drink is not going to do anything. Binge drinking early in pregnancy can be a problem, but if you ever see a pregnant woman with one beer, don't hassle her about it. If you see her with 4 beers, if you know her, then hassle her about it. Illegal drugs at high levels can be damaging to pregnancy. A few prescription medications. But not most. There's a few prescribed medications you can't take during pregnancy. But one of the major things that are harmful during pregnancy is lack of prenatal care. So for all the things that women are not supposed to do during pregnancy, really one of the most important things that they can do is to get prenatal care and have medical checkups every so often. That's one of the best, most important things that we need for healthy births. So we need prenatal care. And there was one other thing I was gonna. Another very important factor is a lack of a certain vitamin called folic acid, which is vitamin B9. That's really important to have early on for neural the embryo. So prenatal vitamins have that. So do regular vitamins. They also have that. So these are the big major things to avoid during pregnancy. And the reason I say this is that a lot of women, like 1 in 3 women, will have a miscarriage with one of their pregnancies at some point. And there's so many things that people say, oh, you're not supposed to do that when you're pregnant. You shouldn't jump. You shouldn't run. You shouldn't get your heart rate up above this certain amount. You shouldn't do this. You drank too much coffee. These are the real things that can have bad effects on fetuses, but not every miscarriage is because the mom has been irresponsible, let's say. So those are the major things to avoid. Oh, here we go. We'll see what this is gonna say. Alcohol in quantity, high fevers. Oh, that one, yeah. Okay. Do you know what this drug is? Accutane? Accutane is, a drug that's prescribed for bad acne. And you have to take a pregnancy test before they give it to you. So that's a prescribed drug that is very, very damaging. If you take it while you're pregnant. Most drugs are not gonna do that much to a fetus. Okay, so next we're gonna kind of go through, okay, here's some things that tend to happen during pregnancy from start to end. And the first one is morning sickness, what we call morning sickness. And this is its actual scientific name, hyperemesis gravidarum. So gravidarum means pregnancy. Hyper means too much. What do you think emesis? What are people doing too much when they have morning sickness? Vomiting. Yeah, emesis is vomiting. So too much vomiting when you're pregnant. Hyperemesis gravidarum. And this is old by now. This is Princess Kate, who is the daughter-in-law of King Charles now. And she, was had the most scrutinized pregnancies in modern days because they're going to be the heirs to the British throne. And when she was pregnant the first time, there were all these like kind of mean memes about her, like she wasn't gaining enough weight. She must be dieting during pregnancy. She actually had hyperemesis gravidarum with each one of those kids. And it's tough to get through. I never had that. I puked one time with all 3 pregnancies and it probably wasn't even related. So lucky. But if it persists very long term, you can need certain medication to help you stop throwing up so that you can maintain enough calories for yourself and the embryo. And the medication is basically an anti-nausea, anti-vomiting medication. I can't remember what it's called.
Zofran.
Thank you. It is Zofran. One version of it. Likewise, sometimes when people are pregnant and they don't have any morning sickness, they think that's a bad sign. There's no connection between your level of morning sickness and your healthy pregnancy outcome. But it tends to happen. Hyperemesis gravidarum is just a few % of women would have that level. Something else? Oh, yeah.
I have a question about this one. So,
Oh, yeah, this relates to your question about what people crave and what they can't eat.
oh, really?
But that's the question that you're actually gonna have.
The one